You might wonder why I yap and I'm profane all over the internet all the time. And I'm yap and I am profane on many different channels. New to YouTube, welcome. But there's a good reason. Well, I think it's a good reason. We don't take any outside funding. We're a 50-state mental health practice. We are fully bootstrapped. Running this business has come out of my own pocket. We found a place we thought we could do good work in, where we could create accessible care for people who have not historically had access to it. We could create something in a world where people have nothing. So even if they couldn't afford complete care, we could give them some other access to services and care that they maybe have not had access to before. And we wanted to do it right. And part of doing it right means not taking outside capital, at least not through the ways that I am familiar with. We'll talk about that. Hey there, if you're new here, I'm Lauren. I go by L2. Yes, you can call me L2. Everybody does. I run a 50-state mental health practice where we provide mental health services to people throughout the country through a variety of modalities, including a more accessible process for adult autism assessment, which is very, very important to us and really germane to what we do. And we are doing it all without any outside help. And that's exhausting. I won't say that it's the hardest way to do things, because I think growing a mental health practice in general is hard no matter how you do it, whether you have investment or not. But I think doing it this way is especially hard. We have no marketing budget. None. No marketing budget whatsoever. All of our money comes from what we are able to generate as a small bootstrapped practice. We have some cash pay services. We have some insurance-based services. We are moving more towards insurance-based across the board. And we take no outside capital. And there's a reason for that. And the reason for that is I have so much experience in this field. I have built multiple practices. I have worked with many, many different startups. I have done everything that you can imagine in this field. I am one of the handful of people in this country who are capable of setting up a compliant 50-state PC MSO structure. I've done it multiple times. My partner and I own 4 practices together. We have taken no outside capital for any of them. But we have also worked with everybody, not everybody, but a lot of people on the other side of that who are doing VC-funded big healthcare. And I am not going to say by any means that everybody is doing it wrong. Not the case. I have people in this space who I adore, who are doing really good work, who are doing mission-oriented work, who are trying to keep things less about the bottom line, more about the outcomes, knowing that the outcomes will drive the bottom line, all of it. But I've also seen some really shitty stuff. I have also seen the people who give you all kinds of lip service for what they want to build, how they want to build it, how they're going to change outcomes, how they're going to fix people, how they're going to fix healthcare. And what they're really saying is, we found a way to bill for something that we can make X amount of margin, which will make our investors 30% over 4 years, which is what our investors want. And at the end of the day, when our business model doesn't work out the way we think it will, because it never does, all of the mission-oriented work that we said we were going to do going out the window, and we are only going to care about the bottom line, which includes abusing our practitioners, reducing services for our patients, and often overbilling for things. There is no way to be in health tech and telehealth specifically, well, all of it specifically, without running into what I call the health tech bros. And everybody who knows health tech knows exactly who I'm talking about. And I want to talk a little bit about what that has done to healthcare, the disparities in access to care as a result, and how it can harm, I should say, patients who are looking for care in the process, and exclude people who could provide really, really excellent healthcare by sending the dollars in the wrong direction. Healthcare is not a profitable business. It was never supposed to be a profitable business. Can you make money doing or delivering healthcare? Yes, you can make money delivering healthcare. Are you going to make the gigantic margins that most VCs think that they should get out of a profitable business? No, you cannot apply a tech business model to healthcare and still deliver good healthcare. You can apply it to healthcare and deliver healthcare, but good healthcare is not coming from that. Not usually. I could prove me wrong. Happy to prove me wrong. Happy to be proven wrong there. Anyway, one of these companies started small, got huge investment, decided that they were going to take on the ADHD space. I say this as a clinic that has products for assessing and in some cases treating ADHD on the smallest scale, because it is very, very difficult to treat via telehealth because the medications are very, very hard to access via telehealth. And if you're going to do it in a 50-state landscape, it is nearly impossible for good reason. It's not to say that the patients who are accessing stimulants are a problem. That is not what I'm saying at all. But the stimulants are controlled for a reason. The medications are controlled for a reason. And that means that you have to be able to operate within state guidelines for prescribing those medications. And that is for a reason. That is because we want to make sure people aren't having heart attacks and dying after taking stimulants for so long without ever having an EKG or a checkup. Right? Like, there are reasons for doing this. I'm not a doctor, but there are good reasons for doing these. These rules did not come up out of nowhere. And it has nothing to do with the patient's behavior. It has everything to do with the reasons that certain medications are controlled. Anyway, moving into the ADHD space and ADHD treatment specifically means that you are going to prescribe controlled substances. That is what most people want when they go for ADHD treatment. Not because they're wrong in wanting that, but because they are the most effective medications for most people for ADHD treatment. Now, keep in mind, I say this as an administrator, not a clinician. So I'm using layman's terms and using the highest level explanations just as a way to kind of demonstrate what is happening. So if you say you're going to get into ADHD care, that means that you're going to be providing care for people who have higher medical needs, who are under higher levels of scrutiny, and clinicians who are under higher levels of scrutiny. These should be highly trained clinicians because, again, these are very controlled substances and they are abusable. Not that they are being abused by the people who are seeking them through these services, but there are people who abuse them, and you have to be able to identify those people. There is an entire training and skill set specifically based on that. Not only that, but you have to have operations protocols in place so that people who are misusing the system cannot be seen multiple times. All of that is really, really important. It keeps people safe. It keeps clinician licensure safe, which is also very important and often overlooked. And it keeps organizations out of trouble. Instead, they realized that if we make it easy to get stimulants, people will just sign up for our services. And they didn't have a way to verify that somebody wasn't signing up multiple times. So people with bad intentions were able to misuse this very simple to use system because the proper checks were not in place. And why were the proper checks not in place? Because the business people who saw the margin were making decisions when clinical people should have been making decisions. And I guarantee you, and I know this from people who were there, that many, many clinical people said it will be dangerous if we do things this way. And they didn't listen. They didn't listen. Why do you ignore your clinical people? You ignore your clinical people when the bottom line tells you otherwise. I assure you, there were plenty of people like me ringing the bell saying, how do we know people aren't misusing this? How are we protecting our clinicians who are prescribing these medications? What training are we giving them? Are we confident in this system? How do we know we're not just giving stimulants to every person who asks for them? Are we doing EKGs? Are we sending people to the primary before so that they get a full physical workup, or are we just giving them the medication? There was definitely somebody, probably many somebodies who said those things, okay? They were ignored. Profits skyrocketed, soared. They were getting investment hand over foot. Look at how these people have innovated in the mental health space. They have changed the game. They've made care so accessible. Look how many people are getting services. What they actually did was take the least expensive people they could by clinicians. So they found the least expensive workforce they could, gave them 15-minute appointments. And this is not a criticism of nurse practitioners. We employ a ton of nurse practitioners. They're amazing, but they're much less expensive than using doctors. And when you're not using mental health nurse practitioners and you're just using anybody with a license, you get a different quality of care. Not to say that they were deliberately practicing bad medicine, but the quality of care is different when you go to somebody with a background in mental health, the background in medication management for mental health, a background in substance use, and a family nurse practitioner who hasn't done a ton of this work. Those are different. So they had a workforce full of people who were trained to assess people for ADHD. And then all of a sudden, the Department of Justice is down their throat saying, we feel like you're overprescribing. The DEA went after them and said, we feel like you're overprescribing. And did they go after the organization first? No. They went after the doctors. They went after the nurse practitioners. Because at the end of the day, the decisions that you make to run up profit margins don't hurt the company first. They hurt the clinicians who assumed, and they shouldn't do this, but they assume that the lawyers have done their due diligence, the compliance department knows what it's doing, and we can just trust them. And they do what they do, and they collect their check, and they leave, and then all of a sudden they have a subpoena in their mailbox from an organization that wants to review all of their medical records and verify that they've actually been supervising the nurse practitioners that they say they've been supervising. Or there's a summons from the nurse licensing board, wherever the nurse is licensed, trying to figure out who was signing off on 200 different stimulant prescriptions in a period of 30 days. And the clinicians are going, but you said this was fine. The clinician should know better. If your clinical judgment doesn't tell you that this is the way to go, then you should not be doing it. But a lot of times they sign out to the compliance people and just treat the patients who are in front of them who they are getting paid to treat. The clinicians are always the first to get in trouble. Always, 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 always. And these organizations do not look out for the clinicians. They look out for the investors. They, over time, pay clinicians less. They pay staff less because the more investment you take, the more people you have to pay out, the more people you're responsible to. And those margins matter when you're in those structures. And I've seen it happen. That's one example. I've seen it happen 10, 15 times. I've been brought in to consult with organizations, and everything they say at the beginning is, all we care about is patient outcomes. We have a great team of investors behind us. That's all they care about too. We're all in on making sure that patients are first, patients get better, and patients are served. We absolutely care about our clinicians. Our clinicians are our life force. They are the product. I can't tell you how many times that has been said to me. All we care about is our clinicians. And then margins fall. Things aren't payable. They get screwed over by an insurance company. Patient acquisition isn't as good as they thought. Clients, they sign big clients who want bigger margins. And now they're squeezing the clinicians and they're asking them to do more with less. They're asking them to see patients faster. They're taking them off of W-2 and making them 1099 when they were promised W-2 forever. They take away their benefits. They try to make care cheaper, 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 cheaper until they run off all the clinicians who have been there from the beginning because they don't want to work for nothing and replace them with a new crop of people who are just signing prescriptions. Happens over and over, over and over and over and over. So we don't take outside capital because one, I don't want to be them, but two, I don't want anybody to tell me how to treat my patients. I'm going to give my patients the level of care that they need, the level of care that makes sense for them. And I have a right to lose money on patients if I want to. And I don't want to explain that to anybody. Sometimes running a good practice looks like running a bad business, and that's not the case, but it is what it looks like on paper. And that's a choice I want to make. That's a choice that I make every day. I do not need health tech bros in my world telling me how to make more money off my patients. I'm really good at making money. I can do that myself. I'm good. We don't take outside capital because what exists in our marketplace are people who treat healthcare like a business that you can get rich off of. And we treat healthcare like healthcare with salaries to pay. And the healthcare we deliver has to pay salaries. That's the point. And that means that we're going to run a really good clinic that will not be running to the ground, hopefully. Some days we have to figure shit out. But we're not going to have dudes in boat shoes and wayfarers telling us how to make our care more profitable. Because profit is never the first consideration. And when it is, you get the DOJ at your door asking why you're overprescribing. There's no limit to the number of what I call health tech bros who are pitching new startups every day. I talk to them less now. There were a couple years there where I was probably talking to 2 or 3 a week. Everybody looking for support, for people to help them do their pitch, for people to help them build clinical operations assistants, people to build out their MSOPC structure, all of it. And because I've done a little bit of everything, my consulting company often got tagged in to try to help these companies grow. And it never failed that they would go from seed or pre-seed to somehow getting $3 million, $5 million, whatever, that they absolutely needed to grow. Meanwhile, I've grown 4 very successful practices without raising a dollar. So the question is, why do you need that money? And where did it come from? And it's just a different philosophy. There are people who think you can't grow a tech company without a huge amount of capital investment. And if you have to build actual tech, then that might be true. You need some investment because if you don't have the ability to pay developers, you can't really build tech unless you're a developer. But do you need a fully functioning operations team or a fully staffed giant operations team and a huge clinical team and to try to launch a product? I don't know. I don't think so. I've done it without it a number of times. There's always a stage in startup growth where you're basically smoke and mirrors, where to the person who's buying, it all looks very fancy, but to the person who's actually running it, it's a spreadsheet and a couple of tools that you manually send out, and things are imperfect and sometimes things get screwed up, but you're learning what you actually need to run your practice or your product or whatever. That time is actually really, really valuable. Because if you build tech before you have that period, you're going to build the wrong thing. You're going to have to rebuild it and you're going to need more money. So the time of cobbling it together and putting together smoke and mirrors and doing things on spreadsheet and email, as much as that gets a bad rap, like that's the way you run it to start, to actually figure out what you need to build. The number of times I have seen health tech organizations build something without doing any kind of MVP work first and then have to rebuild it and spend another $50,000 rebuilding something, 9 out of 10 times. It's that common. It happens that often. I love a bad, clunky system that works. You'll fix it eventually. You'll build the good system eventually. But because you know how the bad, clunky system works, then you can build the good system. All of that is to say, I just have a vision difference on how to start companies like this. And I've done it successfully enough times that I think I get to have my own perspective on it. You can run things with a chalkboard and a spreadsheet and do a really good job on a small scale with very little money. Very little money. You might need money for the salaries that are absolutely vital, but you go without and you figure it out until you actually know what you're building. But that's not the way that most people operate. And I get it. It can be scary to do things that way. It can be hard, especially if you have mouths to feed. It can be overwhelming. So people go out and raise money. But when I say people, I don't mean all people, because the lion's share, something like 90% of VC capital goes to white men, often white men who have raised capital before, often white men who have raised and lost capital before, who have barely made anything on the capital that they raised before. But it was just enough to get them to the next idea. They build programs with the intention of selling them, which is not a bad strategy. Build for 5 years and then sell it to somebody so you get to go take a vacation. Awesome. But it means they take huge amounts of capital infusion up front, or very large amounts of capital infusion up front, and then run it out over and over and raise more capital because they're never going to have to pay that bill off. They just intend to sell it off. That doesn't work in healthcare. It doesn't work in healthcare, or it does. It depends on what your goal is, I should say. If your goal is to create excellent healthcare, to create something innovative that is going to solve a giant problem in healthcare, it doesn't work. If your goal is to create a company that you can sell, it works fine. It works fine. But that company becomes a race to the bottom because it becomes about squeezing every ounce of juice and capital and margin out of it that you possibly can so that the investors are happy, so that the acquiring company is happy, so that there's something to acquire. And patients are the less important part. Clinicians are the less important part in that. You don't care who gets screwed over in the end. And the patients, when you change hands, often get screwed over. The clinicians, when you change hands, absolutely often get screwed over. And if you do shitty stuff in the meantime, which is also very common, that falls on the clinicians, not the business people for the most part. The clinician licenses are what ends up in trouble. I say this a lot, and I will say this over and over again. When a business person gets in trouble, they usually get fined. Maybe they get fined. Often they weasel out of it. No wrongdoing, whatever. When a clinician gets in trouble, they lose their livelihood. And it is that serious. It can be that serious, especially in the health tech space. I've seen it before. So when we make a conscious decision that we are going to build something to sell in a space that is inherently not profitable, healthcare is not a space that has tons of profit to go around. In a space that is not profitable, Something has to suffer. And we know it's not going to be the investors. This is not a healthcare example, but I know the guy who started and ran WeWork. I mean, the company is a shadow of what it was at its heyday. And he had tons of investors and lots of kind of shady, grifty stuff going on there. But I don't remember if he left or he was ousted from WeWork. And like a couple years later, he had a huge investment from one of the biggest VC firms in the world in whatever his new idea was. After he very publicly ran a company into the ground. After there was all kinds of documentation on a really, really shady business practices. But he turned around and got millions and millions of dollars. I mean, probably hundreds of millions of dollars. I'm not even sure. Very shortly after the dust settled. And I don't even think the dust was fully settled. But that's what happens, not across the board, but it does happen. And I've seen it happen. I worked with a company years ago where both of the founders were under very, very public investigation for something. And I had already been gone for a long time by then because I wanted nothing to do with it. They were both under very public investigation, very public. They sold, they left, immediately got investment from the same investors to build a new company. Scot-free, no repercussions whatsoever. That's what happens in our VC spaces over and over and over again. And we're not funding women. We're not funding Black people. We're not funding people with marginalized identities. We are probably funding neurodivergent people as long as they're white, male neurodivergent people, but we're certainly not funding autistic women, certainly not funding autistic Black women. When we say we don't take outside capital, could we get it? Probably. I probably could go through a funding round and get a modicum of capital compared to all the dude bros out there who, have done this 5-6 times. Probably could, but I have to compromise a lot to get it. I don't want to do that. So we'll do it the hard way. The hard way. I don't think either way is actually easy. I think it's both really hard, but we'll do it the hard way because we actually care about our patient outcomes.